This talk is Things We Wish We Knew, Historical Context and Cultural Competency in Global Health Security. My name is Francesca Battelli. I completed the Master in Biohazardous Threat Agents and Emerging Infectious Disease this May. And the PowerPoint that I'm going to talk about today came about after a series of conversations with my classmates about things that were somewhat interspersed throughout some of the courses and some of the lectures, but were largely missing, and that we felt could be really helpful presented in a single concise presentation in a single lecture. So we thought that it was important to do this lecture and to kind of give you one lens through which you can view biodefense, one of the frameworks that you can use to approach it. I'm personally still learning about many of these topics. I'm not an expert by any means, but I hope that you guys can find some great things to take away from it. To start, I'll go over background and then over some concepts and some of these issues in practice. So a little bit of background into the history of global health, and you might already be wondering why I'm framing this lecture or this slide about global health and not health security and biodefense, given the context of the course and the program. And the answer is that really, for better or worse, health security and global health security has become almost entirely synonymous with global health and global public health. And they're all related to the biodefense effort. So for the purposes of this lecture and the figures that I might show, when global health is mentioned, think global health security, think biodefense. So to start off, tropical medicine, which we all associate with infectious disease, emerging infectious disease, low and middle income spaces, it was born out of the desire to protect European colonizers. As they moved into new regions, they were exposed to new diseases, and in order to protect themselves, this field emerged. It grew into international health, which arose a bit later in the 19th century as nations began to realize that health would work better if they could cooperate with each other. So they started having conferences and conventions like the International Sanitary Convention in 1851. And then the Age of Development began during the Cold War as the US and Soviet Union raced each other to, quote, develop former colonies and to advance their own agendas as well. And as the Cold War ended, NGOs and international organizations popped up and they filled the gap. And this is probably what most of us associate when we think about global health today. It's led largely by the US and Europe, and their organizations like the WHO, Doctors Without Borders. But global health is moving and it's evolving. And so today, what's becoming the dominant term or practice is global public health. And this merges the global aspects of health with the local aspects of health. And this is a real big movement to kind of prioritize local communities in the decision making for their health interventions and their health outcomes and their health priorities. Now, both military medicine and medical missionaries also played a large role in colonial medicine. In terms of military medicine, soldiers would often impose draconian health measures to control indigenous populations. And while medical missionaries, they brought individualized medical services to new colonies to, in their eyes, help indigenous populations, many times healthcare was used to displace traditional forms of healing and traditional forms of disease prevention, and in its place introduce Western culture and Western medicine culture. And while some can argue that at times this was really helpful, there are so many examples of where this was incredibly harmful. And one really good example is yellow fever. So before the 1800s, many African cultures maintained the tradition of burying their deceased near their homes, including those who died with yellow fever. And as a result, individuals gained long-term acquired immunity to yellow fever through child case of the endemic disease. And in the 1800s, colonial health provisioners forced these cultures to abandon those practices and those traditions, wrongly assuming that these communities had a natural immunity. And as a result, this led to a dramatic increase in deaths from yellow fever in these populations, on par with those observed in settler populations. organizations. Moving on to what is known as decolonizing global health. Decolonizing global health is a movement that started in low and middle income countries and formerly colonized areas. That it's a movement to recognize and address the legacies of colonialism and imperialism that persist in global health. And the reason why I have decolonizing in quotation marks on the slides here is because there's a debate, and a valid debate, around the appropriate use of the term. Historically, decolonization is a violent process. It returns indigenous land, and therefore many argue that it shouldn't be used as a metaphor. So some other terms that you might come across if you choose to explore this space are decoloniality, global health, or reimagining global health. So terminology is really important, and I'll talk about that in a few slides as well. But here's a good figure. This is the slide with the two circles, where we have some colonial remnants of global health and what they look like when you try to decolonize global health. And on the left side, some things that remain in global health that are legacies of colonialism are things like practices that further strengthen an unequal power hierarchy, right, between a nation that was formerly the colonizer and the area or country or nation or state that was formerly colonized. Organization and regulations that put more power into the hands of the rich and powerful, and this unwritten norm that the, quote, developing world is incapable of solving its own health problems, and therefore, as a result, it is in need of saving, right? In decolonizing global health, these things, they look a bit different, right? And they're guided by principles like development, human rights, justice, multilateralism, more power to the global south, right? Shared prosperity. And so what they look like is building global consensus to remove these practices that exist as remnants of colonialism, moving towards a multipolar global health governance structure, north and south, and pushing for a paradigm shift to believe that through continuous economic and social development, the developing world, and I'll get into these terms in the next slide, they can solve their own problems. So a little bit into terminology. So there are all different terms that kind of come up in this space, and there are some of them that are they're all flawed, but there are some that are better to use than others. So third world is definitely a term to avoid. It's outdated. It connotes superiority and inferiority of one over the other. It assumes universal poverty. It's othering, right? It suggests the existence of this first and then second and then third, alien, different, not of our world. You really won't hear this term used in the professional world of global health and public health today. And if you do, it's not right. Another one that we're moving away from as a field is developing countries. Similar to third world, it implies a hierarchy, right, of good versus bad, or standards of progress based on Western society that don't necessarily exist outside of Western culture. And there are some alternatives, so I'll present those and then I'll tell you some things to keep in mind about them. So we use a lot, and this is a sufficient alternative for the moment, is low and middle income countries, high income countries. But if you use this term, keep in mind that this is a narrow categorization. This suggests categorization and separation by income alone. And when it's used in fields beyond economics, anything from agriculture to health, it may not apply directly. Low resource and high resource settings is another example of a term that's used often. And when this is used at a smaller scale, it can be really helpful, but if it's used at the country level, it undermines complexity, it insinuates homogeneity. We might think of the United States as a high resource setting, but we have many communities that are severely underserved and lack many resources and some basic resources. And another one that you'll probably hear a lot is global north and global south. And while this one's become extremely popular, not only is it misleading, but it's entirely inaccurate. And I'll go into this on the next slide. Here we can see a world map at the top. It's a bit of an older slide, as you can tell by the terminology, but fundamentally it shows this line called the Brandt line, and it separates above it more developed countries, or high income, let's say, and less developed below. And of course, it was developed by a German chancellor in the 1980s to split the world into what he saw as richer and poorer nations. But when you look deeper, it's actually way too simplistic. So this is a figure below it on countries with a GDP per capita greater than 10,000 USD. And when you break it down this way, with countries with a GDP per capita greater than 10,000 in the light blue and others in the dark blue, you see that a division between North and South isn't accurate. There are parts of what Brandt described as the global North that don't have that GDP per capita, and there are countries in what Brandt described as the global South that do. So, all in all, these are much better terms to use than third world and developing, but keeping in mind their limitations when you do use them. So, the goal of this lecture is to dig deeper and to work towards understanding or learning how to understand why we see certain threats, certain biological threats, certain health threats from certain parts of the world. To provide as well a framework through which we may approach the biodefense field. And the idea here is not to make ourselves feel bad or feel guilty for historical events that we did not play a role in, right? But instead to make us feel empowered to make positive changes in our own lives and our own careers. Now I'll go over some concepts that I think demonstrate some of these ideas. So, historical context. It's considering the history of the community, population, or nation with which you're working, and how doing so is vital to doing the best work for them. Normally at this point I would ask the class, where is the highest burden of infectious disease? Where do we usually associate with the highest burden of infectious disease? And the answer is low and middle income countries. And we can ask ourselves why. Right? And the answer are things like infrastructure, access to healthcare, cost of medicines, right? When you dig deeper, a lot of those things can be traced back to decades of colonial occupation and the extraction of resources and unequal power today. And that brings me into power asymmetries. These are legacies of colonialism and empiricism that reveal asymmetries in how global health is run and funded. And on the next slide here is this figure, global health, how global. It's this map that shows the headquarters of 198 global health organizations across the world. Now, despite what we said just a few slides ago about how the majority of the burden of infectious diseases is in low middle income countries, we see 38% of global health organizations based in North America alone, and 46% in Europe. And look elsewhere, 1.5% in Latin America and the Caribbean, only 7% in sub-Saharan Africa. And these include organizations that we traditionally associate with health security and biodefense, right? CEPI, Global Health Security Agenda, Johns Hopkins and Georgetown Center for Health Security. The next slide is also really telling how for every 20 global health leaders, 14 out of 20 are male, 17 out of 20 are nationals of high-income countries, and only 3 are nationals of low and middle-income countries. And what does this mean? Well, who sets the agenda? Colonial-era institutions, right? Institutions that today we associate with excellence in the fields of global health, but that have their roots in the colonial eras. Institut Pasteur, Oxford, London School of Hygiene and Tropical Medicine, Western governments like the United States and the United Kingdom, and NGOs like Doctors Without Borders. MSF itself is based in Geneva, and the United Nations and its agencies like the WHO, which are largely funded by the US and its allies. On this note, who controls the money? On the y-axis here is development assistance for health in 2019 in billion USD, and on the x is donor countries. And overwhelmingly, the majority of the money comes from the US and its allies. And we know, especially in health security and biodefense, that these efforts are overwhelmingly led by the US and even the DoD. So what does this mean in reality? It means that decisions about health priorities for the world's most vulnerable populations are often made without their input. High-income countries dictate resource allocation, and as a result, health and health security challenges are often inadequately and inequitably addressed. And nowhere is this clearer than in the distribution of vaccines against COVID-19 during the pandemic. This figure of a map here, it shows how rich countries were predicted. This is from July 2021. Rich countries will have vaccinated the bulk of their populations earlier than others. In dark blue, you have countries projected to vaccinate the majority of their populations by late 2021. In light blue, mid-2022. In yellow or orange, late 2022. And in red, from 2023 onwards. That is a significant portion of the world, right? Equitable partnerships is another really important topic in this space. Historically, partnerships between researchers or governments in high-income countries and their counterparts in low and middle-income countries have been imbalanced and inequitable, with knowledge transfer and the decision-making coming largely from the groups based in high-income countries who then end up taking credit for the work that is done. And a really good example of this kind of phenomena is parachute research. It's also known as parasitic science. In parasitic science, researchers from high-income countries conduct research and extract samples and data from low and middle-income countries without adequate involvement of local experts and local infrastructure. And as a result, high-income countries disproportionately benefit, right? Academically, financially, because they get the credit on the publications and they get the prestige. And the results of parachute research like this are a lack of long-term, equitable, and sustainable collaborations between high-income countries and low- and middle-income countries. A one-way transfer of knowledge from high-income to low-income countries that ignores indigenous expertise and the inability of local researchers to gain autonomy over their samples, their data, and their research. And this is a really big one in global health security, and especially emerging infectious diseases when we consider how much we value disease surveillance and the tracking of viral evolution and the emergence of new mutations and new species. And very often, these samples are not taken from within our own borders. And it's true as well that high-income institutions, they often have the resources to initiate these studies, right? And they have the technology many times to conduct those studies at the technical, at the laboratory level. But that doesn't mean that the partnerships can't be equitable and can't be sustainable. In terms of authorship and credit, in 2004, a survey of 5 leading medical journals found that only 6.5% of research articles had a co-author from the country in which the study population lived. That is incredibly small. Think about that for a minute. Another group found, conducting a study over 2 decades, that fewer than 50% of infectious disease publications from Africa had an African first or last author. And a systematic review of health research in Africa found that 54% of all authors were from the study country, and 13.5% of all papers analyzed had no local co-authors at all. And I'll take a little sidestep here to tell a story about the importance of equitable partnerships and authorship and credit. So the image that you see here is Dr. Jean-Jacques Moyembe today. And he is a Congolese microbiologist and field epidemiologist. And in 1976, he was in the DRC, then called Zaire. He was sent to investigate an outbreak of a mysterious disease. He arrived in Yambuku in central Congo to find an empty hospital, and by morning, sick people of Yambuku were lining up to be seen by Dr. Moyembe. In his own words, as he recounted these events, he drew blood from the patients, and he witnessed something he'd never seen before. When he removed the needle, blood would gush from the puncture, and the same would happen when attempting to take liver samples with a longer needle. And he recounts that at the time, quote, "We had no gloves in the hospital. My fingers were soiled with blood." Later, he went on to share that he believes it was good luck alone that kept him from becoming infected with what would become known as Ebola. Recognizing how strange this illness was and how quickly it was killing people, he took blood samples from an infected nun and he sent them from Kinshasa to Belgium. And Dr. Peter Piot, a young microbiologist at the Institute for Tropical Medicine in Belgium, he received those samples that Dr. Mayembe sent. Piot analyzed the samples and identified the new virus, Ebola. Until recently, Dr. Piot and his Western contemporaries received exclusive credit for the discovery of the Ebola virus. Dr. Piot did not collect the first samples from Ebola patients. He was not on the ground. And in his memoir, he mentions Dr. Mayembe only in passing, as an eager young scientist constantly bugging him for resources. Dr. Mayembe was completely written out of this part of history. On the next slide, I found this article back from 2016. History credits this man, this is Dr. Piot in the photo, with discovering Ebola on his own. History is wrong. And when I saw this article, I got excited. I said, oh wow, all the way back in 2016, people were starting to realize that Dr. Mayembe was the one that should be getting credit, should be sharing credit with all these other people too. And I thought this would be the case as I read the article, and instead what I found was mention of all the scientists that worked on this at the CDC. Carl Johnson, Patricia Webb, James Lang, Frederick Murphy, who took this photo, and not a single mention of Dr. Mayembe. Thankfully today, when you search who discovered Ebola on Google, the results overwhelmingly give due credit to Dr. Mayembe's contribution. Now I'll talk a bit about language hegemony. So global health and global health security spaces, as we can probably tell, are largely dominated by English. Academic publications, health security assessments, and high-level meetings are overwhelmingly published and held in English. And language inclusivity, it's an essential part of project development and management domestically and internationally. So something that Dr. Steen talks about all the time is about learning new languages and how important that is. And my classmates and I agree with her. So if you plan to work with a given population long term, learning the local language opens up so many doors and so many opportunities for meaningful collaboration, not to mention that some jobs will pay a language bonus if you speak more than English. Otherwise, if you're not interested in this, if you don't have the resources or the time for it, that's perfectly fine. But it's important to include speakers of a given language on your team and to be intentional with how you disseminate information. Along these same lines are the importance of international perspectives. Health security does not exist in a vacuum. And what we've heard all throughout the pandemic is this tagline, no one is safe until everyone is safe. And this was in reference to distributing COVID vaccines so we could get everybody vaccinated and try and stop the pandemic in its tracks. And my classmates and I feel that even if you intend to work domestically, even if you intend to focus on WMD or bioweapons alone and not global health, your field does not exist in a vacuum. The world exists beyond our borders, and as we've learned all too well, borders can't contain pathogens. In order to understand why a biological weapon might proliferate or why a disease might emerge, we have to consider international perspectives and contexts, as well as local histories. And this leads into the next concept, which is cultural competency. Together with an international perspective, cultural competency is an important skill, and it's often neglected in global health. And I'll give a little story here as well. So in 2018, the DRC experienced an Ebola outbreak. There were over 3,000 cases and more than 2,000 deaths. And despite the international community's best efforts, some locals retaliated with violence. They burned clinics, they attacked healthcare workers. And these Congolese communities were fundamentally frustrated with an international response that upended traditional forms of care and isolated their sick loved ones. Doctors Without Borders president Dr. Joanne Liu acknowledged herself that, quote, choices must be given back to patients and their families on how to manage the disease. And to those of us studying health security, whose goal is safety and security and containing an outbreak and preventing the spread of disease, that might jump out to us and say, well, how can patients be cared for by their families? It's Ebola, right? It needs to be stopped. But there are some ways that this is possible. Conducting diagnostic tests at local health facilities instead of temporary emergency response centers is a small step that can make the community feel much more at ease and listened to. Or providing resources to families who wish to care for their loved ones themselves so that they may do so safely, like PPE. Another example that I talk about a lot is the effect of bed nets, the color and their shape on usage. So this is one of many different studies that talks about this from 2017 in Malawi. And they found that bed nets of a preferred shape are 3.55 times more likely to be used, and those of a preferred color are 1.61 times more likely to be used. Now, the color and the shape of a life-saving tool like bed nets might not be your first consideration as a researcher or a health security professional trying to stop an outbreak of a mosquito or insect-borne illness. But many different studies have shown that these simple details greatly affect uptake and adherence. In some cultures, a color may be associated with bad luck or with infertility, and you're asking people to use these in their homes, in their beds where they sleep. So it's incredibly important to consider the local culture and to involve the individuals that you're trying to help in the decision-making process and in the planning. Another example is Nipah virus. It emerged in 1998 in Malaysia. It's originally from bats and later jumped to pigs and then humans. In these initial outbreaks in Malaysia, 40% of those infected died. And the virus itself occurs annually in Bangladesh, where the fatality rate is up to 73%. Now, in Bangladesh, they found that the outbreaks themselves have been tied to date palm sap, and date palm sap is widely consumed in Bangladesh. And they found that Nipah-infected bats were feeding on this date palm sap, and that they shed the virus in these pots that were hanging on trees. And then humans who drank the contaminated sap became sick with the virus, and in some cases went on to spread it to other humans. So, as a little multiple choice thought experiment, how would you stop the outbreak? What are some different ways? And there are a bunch of different options. You could discourage the community from drinking the date palm sap. Simply tell them not to do it. You could cut down the trees, get rid of the problem altogether. No trees, no sap, no bats, no Nipah. Or you could cover the collection pots so that bats can't feed on the sap. And one of these answers is better than the others, and that's C. Because it considers the habits and the values of the local community and doesn't discourage or try to change the behavior in an extreme way. It doesn't remove the trees entirely, but it does stop the spread of disease. It does both, right? It maintains the community's ability to keep drinking the date palm sap, and it also prevents the spread of Nipah virus. Another topic that's really important is centering lived experiences. So in many cases, we may never understand the unique experiences of a given community, especially historically oppressed communities. Therefore, allowing affected individuals to dictate the narrative with their story should be a priority. And this applies everywhere, whether you're a research scientist investigating an outbreak or an intelligence officer interviewing a source. The lived experience of an individual and a community provide incredible context. And this also means that when we're working with our own community, right, or on behalf of our own community, our lived experiences are incredibly important, and to not be afraid to share them and to speak up. Better health outcomes are achieved when decision-making power and autonomy are given back to the communities we're serving. And many of the examples that I've already given demonstrate this. What about in practice? What do these concepts apply to? We would say everything. Strengthening high containment laboratory capacity in low resource settings. It's about using what's available, considering the local context of disease, considering the local resources. Investigating novel outbreaks. You're looking at local expertise, sample ownership and collection, access. Creating biodefense policy domestically or internationally, right? An important policy thing to know is that there's no one size fits all. What works in one place might not work in another. So it's important to center lived experiences, to consider equity, right, in decision making. Disease surveillance. It goes hand in hand with investigating novel outbreaks in many ways. Sample ownership, authorship, credit, sustainability. Collecting and analyzing biological and biomedical intelligence is an important one. For this, you need to understand historical context, the lived experiences, the perspective of the area that you're looking at. Responding to disasters and pandemics, especially medical countermeasures. This one's really important. It ties into the BedNet topic example that I went over before. Local healing practices. Will people take this medicine? Does it fit in to their daily routine? Is it feasible? Is the setting resource poor and makes it difficult for cold chain storage and transportation of a specific vaccine? All of those things are considered when it comes to, or should be considered when it comes to informing research and medical countermeasure development. And even something as what might seem as distant as neutralizing former Soviet WMD stockpiles with partnering nations. Here it's just as important, right? Languages, historical context, cultural practices. What about what this looks like in practice? Ask yourself questions. When you sit down to write an essay, when you write a position paper or an op-ed or a research article, when you read the news, or when you begin or design a new project at work. Some questions you can ask are, what is the history of this country or this community? How did the current government come to power? What historical or ongoing conflicts exist? How may this group view my presence and my perspective? What unique experiences has this group had? What power dynamics are at play here? Who has the decision-making power? And importantly, am I the right person to work on this project? And what does it look like? Take action. Here are some things that you can do every day. Mind map the different factors that may contribute to a problem that you're analyzing. And by doing so, you'll find connections and you'll find solutions there. Involve local community in project development. Ensure that authorship, credit, and funding are shared equally. Consider ways to disseminate information in a language besides English, if necessary. Ensure that projects and interventions are sustainable and that they build local capacity. And this is actually something that the health security field, especially within the US government, does really well internationally. And my favorite one, allow knowledge to flow both ways. We may be the experts in the room on one subject, on biosafety, on biodefense, but local communities are the experts on themselves. Everybody brings a diverse history and a diverse perspective. And while we do have much to offer, there is also so much for us to learn. Remember that when we interact with people outside of our own community, and our goal is to help them, we are and should be invited guests. And therefore our role is to provide support and to provide our expertise so that those individuals and those groups can make the best decisions themselves, informed decisions, and implement them with our support. My last slide here has a number of different resources. Decolonizing Global Health seminar series from Georgetown, an Indigenous Voices, Lives, and Issues toolkit from the library, a really great collection of resources under Decolonize MSF that was put together and kind of jump-started by a number of doctors from Doctors Without Borders who wanted to address some of the colonial practices that continued to permeate the organization. This paper on addressing power asymmetries in global health really sheds light on how many of these topics came to the forefront of the global conversation during COVID. And transforming global health education during COVID-19 was a project that I worked on with a bunch of students and young professionals from around the world about how global health education could be improved by considering all of these topics and the legacies of colonialism. Thank you.